Intake is the most desirable and appropriate method for obtaining nutrients.
How about a
But there
sip of
are
water?
patients with a functional gastrointestinal tract who are unable or unwilling to ingest oral nutrients. In these cases, enteral tube feedings are an alternative. The feeding tube may be inserted surgically, as shown here, or the nurse may insert a feeding tube into the stomach or small intestine as part of a patient's nursing care. This program demonstrates skills the nurse uses to administer enteral nutrition. These skills include feeding tube insertion, administration of enteral feedings, feeding tube irrigation, and feeding tube removal.
My name's Rick. I'm your nurse. How are you this morning?
To help you place these skills into context, you will meet two patients. Mr. Collier is being treated for a draining wound, and he requires increased protein for wound healing. Intermittent enteral feedings have been ordered.
Mrs. Devon, I'd like to check your eyes.
Mrs. Devon has an undiagnosed neurological disorder.
Look straight ahead.
She is unable to maintain an adequate nutritional intake. Mrs. Devon is receiving continuous enteral feedings while she undergoes occupational and physical therapy, as well as a re-evaluation of her care needs. Remember, as you provide enteral nutrition, you need to prevent pulmonary aspiration, plan individualized care and patient education, collaborate with the healthcare team to ensure continuity of care and accurate and timely communication. Apply critical thinking in decision-making and evaluation of the effectiveness of nursing care. Also, perform the skills with care and compassion because enteral nutrition may cause discomfort and embarrassment. Delegation is an important consideration in planning your nursing care, as agency policy may permit assistive personnel to administer tube feedings by syringe or by continuous infusion. However, assistive personnel should never insert a feeding tube or be asked to verify tube placement. Be sure to communicate clearly when you are delegating specific tasks. Clarify the type and volume of formula to be administered and the rate of infusion. Reinforce the importance of having the patient sitting up in bed or in a chair during feedings, and have personnel report any difficulty in administering the formula or any discomfort expressed by the patient. Enteral nutrition is the administration of nutrients by a tube directly into the gastrointestinal tract. The tube may be inserted via the nasopharynx into the stomach or small intestine. Small bore feeding tubes for nasopharyngeal insertion are softer and more flexible than the larger bore tubes and are more comfortable for the patient. There's also less risk of damage to nasal mucosa from long-term placement. Questions to consider in your planning for insertion of a small bore feeding tube include the following. What are the indications for this patient's enteral feedings? What is the site in the gastrointestinal tract targeted for delivery of the feedings? Are the patient's nares patent? Is the gag reflex intact? What is the patient's mental status? And is peristalsis present, indicated by the presence of bowel sounds? Supplies you need for inserting a feeding tube include size 8 to 12 French nasogastric or nasointestinal tube with guide wire or stylet, lure lock or catheter tip syringe, stethoscope, pH indicator strip with a scale of 0 to 14, hypoallergenic tape and liquid adhesive, emesis basin, glass of water and straw, safety pin, rubber band, towel, facial tissues, clean gloves, suction equipment in case of aspiration, pen light to check tube position as it is advanced through the nasopharynx, and tongue blade.
This is a feeding tube. It goes in your nose to your stomach, and you'll get additional nutrition that way in order to heal your wound.
Mr. Collier's doctor has ordered insertion of a nasogastric feeding tube, and you have explained the procedure to him. Position Mr. Collier in a sitting or high Fowler's position. A patient who is comatose would be positioned in semi-Fowler's position to reduce the risk of pulmonary aspiration with vomiting. Before you begin, inspect the tube for rough or sharp edges or clogged outlet holes. Do not insert a flawed tube. Determine the length of the tube to be inserted. Measure the distance from the tip of Mr. Collier's nose to his earlobe to the xiphoid process of the sternum. Then, mark the length with tape or indelible ink. When nasointestinal placement is needed, add an additional 8 to 12 inches. Remove the Lorlock or catheter tip syringe from its package and draw up 10 milliliters of water. Make certain the guide wire is securely positioned against the weighted tip and that both Lorlock connections are fitted together snugly. Then, inject 10 milliliters of water from the Lorlock or catheter tip syringe into the tube to aid insertion of the guide wire. Cut adhesive tape into a 4-inch strip or prepare a tube fixation device. Wash your hands and apply a pair of disposable gloves and inspect Mr. Collier's nares for any irritation or obstruction.
Mr. Collier, there's a couple things we need to go over before we do this. It helps if you drink some water.
Give Mr. Collier a separate glass of water with a straw or a glass of crushed ice.
Okay.
Tell him to give you a sign if he becomes uncomfortable during the
The
procedure.
other thing is, if it's very uncomfortable and you can't talk, I just need you to raise your hand and give me an indication that you're not tolerating this very well.
To begin, dip the tube into a cup of water to activate the surface lubricant.
It's easier for this tube to go down if they're drinking some water.
Okay.
So this is going to go part way into your nose, into your throat. I'm going to have you lean your head forward like you're trying to touch your chin. Exactly, exactly.
All right.
And as we do that, if it's more comfortable for you to take a couple drinks as we advance this, feel free to do so.
So you want me to hold this?
Yes, do.
All right,
Yeah,
okay.
whatever is comfortable
Okay.
for you, actually.
Gently insert the tube through the nostril
I'm
to the
ready.
back of the throat. This step is uncomfortable and may cause Mr. Collier to gag.
Just breathe deep.
Aim the tube toward the back of the throat and down toward the ear.
All right, you lean
Ask
your head
Mr.
forward.
Collier to flex his neck so his face is close to his chest after the tube has
to
passed
drink,
through the
go ahead and drink.
nasopharynx. This maneuver should close the glottis and reduce the risk of inserting the tube into the trachea. Advance the tube as he swallows,
Take a nice
rotating
deep
the
breath
tube
for me.
180 degrees to reduce friction. When the tip of the tube reaches the carina, about 10 inches in an adult,
You okay?
stop and listen for air exchange from the distal opening of the tube. If you hear air, it could mean the tube is in the
Okay.
respiratory tract and the tube must be removed and the procedure repeated. Use your critical thinking skills throughout the intubation procedure. And do not force the tube if resistance is met, or there are signs the tube has entered the trachea, such as coughing, choking, or cyanosis. Instead, stop the procedure and pull the tube back. When there are no problems encountered with insertion, leave the guide wire or stylet in place until the correct position is confirmed by radiography. To secure the tube, first apply tincture of benzoin or other skin adhesive on the tip of Mr. Collier's nose and give it time to become tacky. Use a clean 4-inch strip of adhesive tape and split one end of the tape strip lengthwise about 2 inches.
Nice deep breath, sir.
Place the wide end of the tape on Mr. Collier's nose and then wrap each of the smaller strips around the tube.
You okay?
I'm fine.
Good.
You also need to check for proper placement of the tube at this time. Draw up 30 milliliters of air into the syringe, attach the syringe to the end of the feeding tube, and inject the air. This burst of air makes aspiration easier. Now pull back on the syringe and aspirate 5 to 10 milliliters of gastric or intestinal contents. Observe the character of the aspirated material. Gastrointestinal contents are usually cloudy and grassy green or tan to off-white in color. Intestinal fluid is usually a deep golden yellow and is more transparent than gastric fluid. The color can help to determine the position of the tube when pH readings are not definitive. Measure the pH of the gastric contents using a pH test strip. Compare the color of the strip with the color on the pH chart. Gastric pH is usually equal to or less than 4. The pH of intestinal contents is usually greater than 6. The pH of pleural fluid from the tracheobronchial tree is generally greater than 6.
And hook it onto your gown so that it doesn't
To
get
prevent
pulled
pulling on the
out.
tube, loop a rubber band around the tube in a slip knot. Pin the rubber band to Mr. Collier's gown. This helps to anchor the tube and reduce irritation to the nares.
Can I get a toothbrush?
Help Mr. Collier with hygiene and comfort and tell him when he is scheduled for radiographic confirmation of the tube's position. After
gonna have the
confirmation of
X-ray
feeding tube
folks come up
placement,
here.
the stylet will be removed.
And they'll be up here shortly.
Then, properly dispose of your supplies, remove your gloves, and wash your hands. Enteral feedings may be administered on an intermittent basis or as a continuous infusion. With each, the initial feeding or infusion rate may be low volume, then advance slowly toward the desired therapeutic level. Questions to consider in your planning include the following. What is the patient's current nutritional status? What are current laboratory values, such as albumin and fluid and electrolytes? What are the physician's orders for the feeding formula, rate of infusion, and frequency of feedings? How much total free water is recommended for daily infusion through the feeding tube? And what bedside assessments, such as blood glucose, should be performed prior to feedings? You are preparing to initiate tube feedings for Mrs. Devon, who will receive a continuous enteral infusion. Always check the expiration date and the integrity of the container. The formula
check it
should
for
be
the
at room
expiration
temperature
date and
and
it's
shaken. Other supplies you need include a 30 milliliter or larger Lorlock or catheter tip syringe, stethoscope, pH indicator strip, disposable gloves, infusion container or bag, and tubing. An infusion pump designed for feeding tubes is required when feedings are delivered continuously or to the intestine.
Mrs. Devon, I'm going to listen to your stomach. I want to see if I can hear any bowel sounds. This lets me know whether you're digesting your food or not.
Always auscultate for the presence of bowel sounds before initiating a feeding. An absence of bowel sounds may indicate a decreased ability to digest or absorb nutrients. If there are no bowel sounds, report this to the physician before initiating or continuing with enteral feeding. Place Mrs. Devon in high Fowler's position or elevate the head of the bed 30 degrees. Then wash your hands and put on gloves.
Feeling any better?
Because you are hanging a new bag of formula, it is important to confirm proper tube placement and to assess gastric residuals. This must be performed at least once every 8 to 12 hours and before medications are administered through the tube. Draw up 30 milliliters of air into the syringe, attach to the end of the tube, and inject the air. Then, aspirate gastric contents to check for gastric residual and to measure the pH of the gastric aspirate. A gastric residual greater than 100 milliliters may indicate delayed emptying, which should be reported to the physician.
And this goes back in.
Return aspirants of less than 100 milliliters to help prevent fluid and electrolyte imbalance. A gastric pH of 1 to 4 is a reliable indicator of proper tube placement in the patient's stomach. Hang the filled feeding container and tubing on the IV pole. Insert the tubing cassette into the infusion pump and set the prescribed rate. Allow the pump to prime the tubing. Then, connect the tubing to the proximal end of the feeding tube. Remember, the maximum hang time for formula is 8 hours in an open system and 24 hours in a closed, ready-to-hang system. Start the infusion at the current prescribed rate. Remember, an initial infusion is usually regulated at a rate of 30 to 50 milliliters per hour. It is then increased by 10 to 20 milliliters per hour per day as tolerated to achieve the target infusion rate. You have explained the procedure for administering an intermittent tube feeding to Mr. Collier. Auscultate for bowel sounds first.
Well, your stomach's working good.
Then, place Mr. Collier in high Fowler's position or elevate the head of his bed at least 30
When we do
degrees.
these feedings, we need to have your head up.
Okay.
Apply gloves and determine proper tube placement. Consider both the results of pH testing and the appearance and volume of the aspirate. Return the aspirated contents before you begin the feeding. Then, draw up 30 milliliters of water into the syringe and flush the feeding tube to be sure it is patent. Initiate the feeding by first pinching the proximal end of the feeding tube. Remove the plunger from the syringe and attach the barrel to the end of the tube. Fill the syringe with the measured amount of formula. Release the tube and elevate the syringe to no more than 18 inches above the insertion site. Allow the syringe to empty by gravity and then continue to refill the syringe until the prescribed amount has been delivered. Following intermittent infusion, or at the end of continuous infusions or administration of medications, flush the tubing with 30 milliliters of water using an irrigating syringe. Repeat every 4 to 6 hours around the clock, following the dietitian's recommendation for the patient's total free water requirement per day. Use your critical thinking skills as you evaluate feedings and the patient's physiologic response. Include the following assessments in your evaluation. Measure the amount of gastric residual every 8 to 12 hours. Monitor total daily intake and output, and weigh the patient daily until the maximum administration rate is reached and maintained for 24 hours. Also, review laboratory data for the return of normal values. Your recording of enteral feedings should include the amount of residual, type and amount of each feeding, the patient's tolerance of the tube feeding, and the patency of tubing. Report any adverse effects. Another alternative is a feeding bag. If such a bag is used, attach the gavage tubing to the end of the feeding tube. Set the rate by adjusting the roller clamp on the tubing. Allow the bag to empty gradually over 30 to 60 minutes to reduce the risk of abdominal discomfort, vomiting, and diarrhea that could occur with a bolus or too rapid infusion of formula. Label the bag with the tube feeding type, strength, and amount. Include the date, time, and your initials. Change the bag and the tubing every 24 hours.
Mrs. Devon, how are you feeling?
Patency of the feeding tube is essential to ensure the delivery of prescribed feedings at the prescribed volume. Irrigation is used to maintain the patency of the tube. Factors to consider in determining the need to perform tube irrigation include the following. What is the character and volume of aspirated gastric contents? Thick secretions and a reduced volume of secretions may indicate the need to irrigate the tube. Conversely, an excess volume of secretions may indicate delayed gastric emptying. Also ask yourself, how does the rate of infusion compare with the ordered volume? Failure of the formula to infuse as desired may indicate development of or the presence of obstruction. Your supplies for irrigating a feeding tube include a 60 milliliter catheter tip syringe, normal saline or tap water, towel, and disposable gloves. Wash your hands before you begin. Then prepare your equipment at the bedside and apply gloves. After determining proper positioning of the feeding tube by measuring the pH, Draw up 30 milliliters of normal saline or tap water in the syringe. Kink the feeding tube while you disconnect it from the feeding bag tubing or while removing the plug at the end of the tube. Insert the adapter, release the kink in the tubing, and insert the tip of the syringe into the feeding tube adapter. Then slowly instill irrigating solution. If you are unable to instill fluid, the tip of the catheter may be lodged against the stomach or intestinal wall. Repositioning the patient may help to correct this. Notify the physician if you are unable to irrigate the tube. After irrigating the tube, remove the syringe and reinstitute the tube feeding or administer medication as ordered. Remove and discard your supplies. Then remove your gloves and wash your hands.
Okay, you doing all right?
Collier.
Hi.
Hey, good news. You
Mr.
take that
Collier's
tube out
feeding
today.
tube is going to be removed.
I know you've been waiting
His
for
wound
that.
drainage has
Ready.
stabilized
Yeah, the
and he's
doctor says
beginning
you've
to
been
eat
eating a
and
lot,
is tolerating
that
his
wound looks a
diet.
lot better, so
You explain the
I think today's
procedure to
gonna be
him
the
and
best
reassure
time.
him that tube removal is less distressing
No, I'm
than
ready.
insertion.
Let me wash my hands and I'll be right back.
Wash your
Great.
hands and apply disposable gloves before you begin. Stand on Mr. Collier's right side if you are right-handed, the left side if you are
All right, Mr.
left-handed.
Collier. You are
Hand
gonna
Mr.
wanna
Collier
hold
facial
this.
tissue and
Okay,
place a
All
clean
right,
towel
I have that
across
ready.
his
I
chest.
want you to hold, take a deep breath.
Tell
and
Mr.
hold it
Collier to
when I
take
tell
and
you.
hold a deep breath.
Let me just get the
Clamp
tape
or kink the
undone.
tubing securely. Remove tape and withdraw the tube steadily and smoothly into the towel.
All right, take a deep breath for me, sir. And blow it out.
Dispose of the tubing and any equipment.
All right, you all right?
Yeah, that feels better.
Yes, sir. I know it does. I'm gonna just kind of
Clean Mr. Collier's nares and, if needed, provide mouth care. Then position him for comfort. Remove your gloves and wash your hands. Record the time and type of tube withdrawn and the patient's tolerance of the procedure. This program has demonstrated essential techniques for administering enteral feedings. These techniques require several skills that must be performed competently and with attention to the patient's comfort and privacy. Individualized assessments, collaboration with the healthcare team, and compassionate care are equally important in maintaining the patient's well-being and sense of self-worth.